My name is Katie Healis, and I'm the interim CEO of Addictions and Mental Health Ontario. Thanks for making the time to meet with us virtually today. Before we get started, we are asking that if you can, please turn your video on so we can see you. Please ensure that you're muted unless you're speaking, just so that everyone can hear each other clearly. You have other ways to communicate with us through the chat or through the Q&A section if needed, so feel free to reach out if you have any other questions or concerns. Thanks for joining us today. Welcome to today's webinar titled The OHT Dilemma, which is a lens on prioritizing and aligning to manage organizational capacity. We know that this is a really hot topic in our sector and across the healthcare system, so thank you for making the time. The objective of our conversation today is to offer some concrete approaches to manage leadership challenges within mental health and addictions organizations related to OHTs, system demands, multiple accountabilities, and the efficient use of internal resources and quality improvement projects. This project today is brought to you by the Excellence Through Quality Improvement Program, our E-QIP team. So our E-QIP is a quality improvement program focused on leadership and capacity building, and is delivered by three lovely partners: Addictions and Mental Health Ontario, CMHA Ontario, as well as the Provincial System Support Program at CAMH. E-QIP is funded, delivered, and partnered with Ontario Health. So thank you all for joining us today. Before we go any further, we do want to take a moment to pause and do our land acknowledgement. So for that, I will pass it over to Maria.
Thanks so much, Katie. My name is Maria Papadimitriou, and I'm the Director of Quality and System Transformation at Addictions and Mental Health Ontario. And I'm really grateful to welcome you all today with the land acknowledgement. We do this for a few reasons. Firstly, to respond to one of the many calls to action in the Truth and Reconciliation Commission report. Starting our webinars and meetings this way also encourages us to reflect on the ongoing impact of colonization on Indigenous peoples and on all of us. Because we are meeting virtually, I'll locate myself and acknowledge the land I'm joining from. I'm a white settler of mixed European and Mexican Raramuri ancestry, and although I have Indigenous ancestry, I am not culturally Indigenous and do not have lived experience of anti-Indigenous racism. I'm joining you from Treaty 19 territory. The Adjutant's Purchase was signed with the Mississaugas of the Credit in 1818, covering a parcel of land that includes what is now called Brampton and Milton. And I would like to acknowledge all those who are present stewards of this land. I also acknowledge that the disproportionate harms Indigenous people experience due to mental health challenges and substance use is a direct result of colonization, and that colonization and racism continue to influence social structures such as drug laws, the legal system, child welfare, and healthcare, including mental health and addiction services. It's really important to ground ourselves in this context as we contemplate and make decisions on behalf of our organizations that will impact the people accessing our services, so that our decisions may always move us and our work towards reconciliation and healing relationships with Indigenous nations, people, and the land. So I'll end by encouraging all of you to reflect about the treaty history and colonial context of the land that you're joining from. And if you don't know, to take some time today to learn about it and include that learning into the context of your work. So thank you, and back to Katie.
Thank you, Maria. I'm pleased to introduce today's facilitator, Paula Blackstein-Hirsch, who will be supporting us in today's conversation. I'm sure many of you know Paula or have interacted with her throughout the healthcare system. So Paula delivers consultant training and implementation support to help organizations achieve sustainable performance excellence. She has developed expertise in organizational and system level quality improvement. She has a special interest in the role of boards and senior executives in leading quality and safety as a core business strategy and the meaningful engagement of clients and families in improvement. She has over 30 years of experience in healthcare and has led system level improvement initiatives provincially and nationally in the hospital and community-based sectors. She is currently a core faculty member for the Master's Degree Program in Quality and Patient Safety at the University of Toronto, and is a faculty with the Central Support Team for Ontario Health Teams focused on shared governance, leadership, and accountability, delivered through the Institute for Health Policy Management and Evaluation at U of T, which is also sponsored by the Ministry of Health. As you can all tell from that impressive bio, she has a lot of experience in this sector, and we're very grateful for her to lend that experience to us today and support today's conversation. So thank you, Paula, for joining us and for really leading us in today's conversation. And with that, I'm going to hand the floor over to you.
Thanks very much, Katie. And I'm thrilled to be here with all of you today. I do want to say that I know that many of you come from a broad number of different kinds of agencies. Today's content was designed to be targeted to mental health and addictions community-based agencies, but it will be pertinent to anybody who is sitting at multiple OHT tables, so a member of multiple OHTs. The second thing I wanted to say is, right at the outset, I don't have any silver bullets, if that's what you came for. But what I do have are some suggestions, some guidance that maybe will be some considerations or some questions that you haven't considered in the past. And importantly as well, I know that there's a lot of expertise from people who are joining us today, and I think it's equally important for us to always learn from one another. There isn't enough time in an hour and a half to really go into lengthy breakouts, but there certainly is time for interactivity. I've built some of that into this, and I'm also really looking for some dialogue and questions as I go. So please, if you have a question, I know that Noshiba is going to be monitoring the chat and moderating questions. I'm happy to answer questions as we go along, and I've intentionally inserted some at certain points in time. So with that, we will get into it. And so, Ashley, if you can share your screen, and hopefully this, my ability to advance them will pop up again. There you go. Okay, thank you. So we're going to start today's conversation just by setting some context. And first of all is just the vision for OHTs. And I am going to look to you in a few minutes just to get some context about all of you who are joining us today. I don't think that there's any debate by anyone, not even beyond the borders of our own country, internationally, about the need for better integrated service delivery for all of the people we serve. And every single healthcare system around the world is striving to figure out how to do this better. There are, however, even within the boundaries of Ontario, a whole variety of approaches to figuring out how best to do this. The government, as you know, put a stake in the ground with the Connecting Care Act, which lays the foundation not only for the approval of OHTs in Ontario as a way for organizing and striving towards better integrated care, but also this legislation importantly places a legislated accountability for every organization that becomes a signed member or party to an OHT. So accountability for striving towards and achieving and contributing to shared outcomes for better integrated care. So that's the focus. That's what's being put down as the foundation provincially. And then the way in which this is happening, as I said, varies in a variety of ways across the province. So I'll just give you a bit of a landscape. I don't know whether any of you, and I didn't put this into the poll, actually it'd be interesting just to see hands up at this point before I get any further. If any of you are participating in the Advanced Leadership Series that's being offered as a central support for OHTs, if you can just use the reaction button to put a hands up if you're participating or have participated in the past in that advanced series. I thought I recognized some of you from that. So just a few. Okay. So we just did, I mean, we get, you know, information just through participation in that series, learning from all of you. But I just did an environmental scan as well about a month and a half ago that compiled information from a good half of the OHTs that were formed through cohorts 1 and 2. And there is considerable variability in the way in which this is playing out across the province. So in terms of who, and when I say who, I mean who are members of OHTs, as well as who is sitting at that leadership council table, which tends to be the senior leaders of participating organizations, the number of individuals who are involved. So the number of organizations that are members, and that will likely grow over time, but also the number involved at that leadership council table. And that's important in terms of trying to balance the need for inclusivity when you're looking for authentic collaboration, but also efficiency in decision-making and finding that sweet spot. And I have some thoughts that I've just sort of evolved over time by being involved with this in terms of how best to balance that and how to think about who ought to be at that leadership council table, but not the focus for today. There are also variability in terms of the levels of membership and the levels of engagement across OHTs. So that's the who. The what. Most organizations are focusing both on enablers, things like technology platforms, engagement of clients and families, as well as the priority populations. And there are deliverables related to all of those. And so it's just variable, the emphasis that some OHTs place on some versus others. And then finally, the most variability is how various OHTs are going about this. So there is considerable range in the infrastructure or the committee and working group infrastructure to support the work of the OHT. There are differences in the processes that OHTs are using for engaging individuals from partner organizations, as well as for making decisions. There's significant range in the size and the functions or the skill sets in what we call backbone or the secretariat that is supporting the work. Various approaches to service delivery redesign, and I know many of you are working with RISE, and we have some RISE colleagues on this call, and they're helping OHTs to determine how best to segment and risk stratify, as well as start into improvement. There are some OHTs that are using more or less quality improvement methods for doing this work, and I think you all know where my bias is on that continuum. Some real differences in the degree of distributed leadership, and this links a bit to our focus for discussion today, because to the extent that there is more distributed leadership involving a good number of people from your organizations throughout the infrastructure, the less burden, the less workload on senior leaders sitting at multiple tables. There's variability in the extent to which OHTs have involved their boards, and differences in the mechanisms or tools for establishing the vision and the priorities in the first place, in the tools being used for oversight, and the tools being used both within an OHT and then at partner organizations for accountability for what different partners have committed to. So just a bit more on background. We know that OHTs have been designed around attributed populations, which means not by geography, which I know is often cases the way in which your organizations think about service delivery to the clients that you serve. And the rationale for that was that geography doesn't always reflect how individuals access care, particularly in urban centers. However, that said, one key consequence of that is that, like many of you, there are organizations that are sitting as members within more than one OHT, and that creates the dilemma we're focused on today. The consequence of that is not only sitting at multiple tables to plan and redesign service delivery, but also importantly, the potential for each of your individual agencies to have to deal with multiple approaches that get standardized within each OHT for delivering service. And that creates huge challenges for individual organizations. So trying to think about methods for mitigating against that risk. And we'll talk a bit about that. And I would love to hear from some of you who have started thinking about how best to manage that. So I just wanted to go back to some basics, just again, as part of our context setting. Within the leadership series, we're using a framework that is core to many social impact collaborations, and that is the collective impact framework developed by Kanya and Craner. And they have these 5 elements of collective impact that help us to achieve collaborative success, or integrated care in this case. And when they did their research on the 5 elements, what they found is that the 3 on the far left are 3 of the elements that are important to have in place early on. So that backbone support, or those core skill sets that are going to support the infrastructure, help the leaders from member organizations to get the work done, continuous communication, and we'll talk a little bit more about that later, and the common agenda. And what I mean by that is it's the vision for the OHT at a high level, but also those priority populations, the areas now that OHTs are focused on, and then evolving over time and spreading that to multiple subpopulations until every door is the right door at maturation. So once those are put into place, it leads to then being able to focus on mutually reinforcing activities, which are defined as, and again, this is important for our discussion today, because it's not only about putting new things in place. It's not only about addressing gaps in service. It's also about what's already in place that might link to our shared outcomes. What new things do we absolutely need to add? And then how do we wrap coordination around both existing and new services to make things seamless for our clients? And then, of course, shared measurement. Measurement to say, do we have full uptake of the things we're trying to put into place to get to better integrated care? And measurement to say, have we had an impact on our key outcomes of interest? And importantly, key message from this slide, not only the focus on what do we already have in place that can help, but the backbone supports that again, and I know that one of the constraints is funding, but having those backbone supports in place that can lessen the burden for leaders and others in your organizations. So I'm almost at the end of our context setting, and what I wanted to do was just round this out by asking all of you some questions. So somebody, I forget who, is going to launch our poll. I think it's Laura. And we're particularly interested, and there are options for those of you who aren't in provider organizations and therefore not necessarily members of an OHT. We're trying to get a sense of how many you're a member of, how many leadership council or steering committees you sit at, how many committees and working groups, and for those OHTs where you're a member, where there is a focus on mental health and addictions as a priority population. So if you can go ahead and launch that poll, and then we'll take a look at the results. And they're all single choice. Ashley, I can't see them coming in, so hopefully you can, or Laura, hopefully you can figure out.
Got about 17 respondents, Paula. So we'll wait maybe another minute. Laura, I think we can share the results if you want.
Okay, so for number 1, okay, a majority of you who are on today who responded are at 3 or more. Wow. A third of you who are at 1, just 1. Okay. The answer to the second question, if I just scroll this down. Okay, interesting. I suspect that the answer to this question is in part because you may be on this and your organization is a member of these various OHTs, but your senior leaders who are on the Leadership Council tables are not on the call. Can you just raise your hand if that's the case? I'm getting at least 1. Okay, well, let's go to the third question. Yeah, I suspect this aligns somewhat with what I just, the hunch I just shared, because it would be more likely then that some of you would be at various committees and working groups. Okay. Okay, and the final question is, okay, it's a priority for most of you, so that's good. And I would say, so we can stop sharing for now. I would say that although I appreciate it's a challenge being at more than one OHT table, one of the things that you are lucky about, you may not share this view, but at least one of the mandatory indicators that people are looking at is for priority population. And one of the common priority populations is one that links to the work of many of your agencies. So I think that that's a plus. Any questions before I move on into the next section? We've sort of rounded out the context setting.
Paula, there's a couple of comments and I'll just read them off.
Okay.
Is it Carrie Herndon? For context, beyond the OHT context, community-based agencies are also expected to further community safety and well-being plans, which is another sizable endeavor for improvement. And thank you, Carrie, for sharing that. I hope I'm saying your name correctly. And then Jennifer from Thunder Bay, it was difficult to answer because in the Northwest, there are 2 OHTs still at the EOI stage, Thunder Bay and District.
Okay, yeah. So you might have some sense of what is on the horizon, but not yet approved. Okay, and I didn't quite hear, Nosha, but what was it that the first one was relating to that some agencies are
I think what Carrie's raising is competing priorities and different accountabilities. I am assuming it is what she's referring to. She or he is referring to community safety and well-being plans. And so I don't know. I'm going to say it again. Whether it's Carrie or Siri,
Sorry,
maybe.
do you want me to jump in? It's Carrie.
Yes.
You actually are
Hi,
pronouncing
Carrie.
it.
Thank you.
Yeah, you're pronouncing it right, which is a rare thing. I'm just wanting to flag that within the broader context, community-based agencies are not just dealing with Ontario health teams, and I didn't answer my question right. We're actually a part of 3, but actually only actively involved in 1. But we're also working in the space of community well-being safety plans, and mental health is an identified area in those plans. So the same kind of integration, just coming from a different ministry. So again, it's a layer upon layer of system changes at the highest accord. So it just compounds this conversation, I guess is what I'm saying.
Okay, and Carrie, what ministry is sponsoring those plans?
Attorney General.
Oh, interesting.
Yeah,
Okay.
it's mandated. So they're community safety and well-being plans for each community. It's a big piece of work.
Wow. Okay, I had not heard of those before. Thank you for sharing that.
Paula, there's 2 more comments. I'm just going to, just because they relate to your poll. Elizabeth McKeeman has said as well, you didn't ask how many OHTs are in your community. We have 5, but only partner in 2. And then Michelle Donald, in terms of OHT committees, I think many organizations are up to 3 to 4 committees per OHT, even if we have several OHTs that we are partnered with. Really require the distributed leadership across the organization.
Yeah, agree. And I'm perfectly aware that there may be more in your community than you're actually a member of. And maybe we can loop back to this question towards the end. But the question is, did you not partner as part of those OHTs because your clients aren't actually served by the other organizations there for the most part? Or is it because you just couldn't partner with anymore, but you've actually got a good number of clients going to those? So that would be an interesting conversation. So let's move into some accountabilities. I'll walk you through this. We'll start within this triangle and focus at this small g governance table, which we have often framed as the collaboration council, called the steering committee, called leadership council, called a whole range of things. This is where the oversight and a lot of the initial decisions are being made. And then there are a number of working groups, committees, advisory groups that report into collaboration council. And of course, several OHTs have client and family advisory groups or patient family advisory groups, depending on what they call them. Generally speaking, the people who are in this triangle are representatives of their organizations and so are accountable to senior leaders and board members within their organizations. The two areas that are kind of evolving and more evolving now as some OHTs are maturing are the purple and the yellow ovals. And so what we're seeing evolve here is that these sector constituencies where more and more organizations are becoming members of an OHT. Not everyone can be at this decision-making table. Not everyone necessarily wants to be at that decision-making table, but really important to have two-way communication here so that there's an ability for these sector tables to influence decisions being made on behalf of the OHT. This is often now starting to be where leadership councils have terms of reference and tenure, where nominees for the next people who will sit at this table come from. And secondly, that the collaboration council communicates back out to these sector constituencies so that there's really good information flow in two directions. And then similarly, at a board level, there are a number of OHTs where there have been board-to-board dialogue sessions. There are some that have a table for board members. And I think particularly important where in many cases they have been actually the board chairs for the people sitting here. In a way, I don't think that makes sense. In a way, I think it makes more sense to organize it like these sector constituencies where from the board-to-board sessions, there's nominations for cross-sector representatives of board chairs that reflect the continuum sitting at a table at a time when the OHT thinks it makes sense to have chairs of boards at a table. So that's all of this. And then of course, the external accountabilities, first and foremost to the residents of the attributable populations, but we will focus today discussion on some of the external accountabilities to the Ministry on Ontario Health. And we know that some of those accountabilities are shifting over time to fewer to Ministry of Health and more to Ontario Health as things evolve. So it is an inherent complex array of accountabilities. And this is only related to individual agencies and this particular system entity, OHTs. So these are some of the deliverables that are linked to OHTs that members are accountable to Ontario Health and the Ministry of Health. And what happens as a result of all of this is that it's a lot. Those are a lot of accountabilities. The timelines on many of them, as we've heard, are extraordinarily short. And despite the organizations who are requesting these knowing that authentic collaboration takes time, nonetheless, the timelines don't get extended. They're very short. And there are a number of competing priorities. And so we know OHTs started with some deliverables around building blocks, around some key indicators that they said they would be accountable to the ministry for, and hopefully some of those would have been the priority population outcomes. Now there's the E-QIP, which is mandatory. and for which there are mandatory indicators, and those don't necessarily align with those initial OHT indicators that OHTs are reporting to the ministry. and then there are also evolving accountabilities to Ontario Health, which relate to involving people in vaccination efforts, and now to the recovery efforts and other things coming. So it's a very dynamic environment, and there are a lot of competing priorities, and those agencies are aware of some of the challenges that OHTs are facing as a result of them. We're going to focus today on these two that are in the red box, the E-QIP and some of the other OHT specific indicators. And so one of the important things is not just what those are, but it's how leaders make sense and prioritize. And in some cases even push back. But it's how do you make sense of all of this? How do you ensure that you're staying true to the priorities that you set as a leadership group and continue to focus on that and help to make sense and, of course, report on what you're accountable to, but really prioritize what you believe is going to serve the residents of your population most. So I've chosen here to focus on the E-QIP indicators, but it may be that none of these three are the current focus for your improvement efforts within your OHT. So are you able to just, maintain current performance on these indicators, know what they are, know that you're doing reasonably well, even though, maybe not as ideal, drill down over time to maybe understand if there are some opportunities for improvement, but focus on moving the dial on the priority indicators that you decided to focus on linked to your priority populations. And you may or may not insert them into your E-QIP. That's what I put into the next box. So another way of dealing with this is, it may be that one of these that, mental health and addictions mandatory indicator is a focus for you, and that you just monitor these and that you actually insert other indicators that you're working on and are focused on that are outcomes for you. And really the key message is here, it's something that's mandatory. Quality improvement plans are a good mechanism and tool for planning and working through improvements, but make it your own. Put into it the priorities that are meaningful and useful to you and make it your own. And so I'll just pause there and just ask the question. I'd be interested in hearing whether you want to put it in the chat or whether you want to unmute yourselves, just to hear from some of you about how you're navigating the E-QIP deliverable among the many other competing priorities that you have. Are you doing some of what I've just talked about? Have you got other strategies that might be helpful to others who are on the call today? Anyone?
Nothing in the chat yet. Carrie's got her hand raised. Carrie, please go ahead.
I don't know if this will be helpful. I'm in the region of Peel, so we have 3 Ontario health teams, all hospital-based. And with the pandemic, basically 2 of them, any kind of communication is a huge issue. So I couldn't even possibly begin to answer this question. The third one has a focus on mental health, and there's work being done and things are moving and churning along. But in 2 of them, to give you some sense of where we are, at least in Peel, and I share this because this may resonate in other areas. And I'm child and youth mental health, community-based mental health. So there's a whole other dimension to Ontario health teams from that perspective. We're engaged in the one but not the other 2, to the point where leaders in the Peel community have come together to try and figure out how to crystal ball information, how to try and understand what the heck's going on in an attempt, to your earlier slide, to begin to influence, or in hopes of being able to influence. But the focus really right now is on trying to open up communication pathways to find out, under the umbrella of the pandemic, when and if they are returning to this work, or what they've been doing behind closed doors that they haven't told us about yet. So,
Are you at the Leadership Council table?
no, mental health wasn't invited. So it speaks to 3 very different ways in our jurisdiction, 3 very, very different ways of constituting and moving forward the Ontario Health Team. So the variabilities you talk to are very real, and very challenging.
Okay. I have some thoughts about that, but we can talk about them towards the end if you want, but I'm sort of evolving some thoughts and guidelines around who ought to be a member at the Leadership Council table if the objective of OHTs is integrated care across the continuum of care. Anyone else want to share?
Paula, Amber from Middlesex London OHT has raised that they are asking for an extension on their C-QIP timelines, just as a note. And so for others, I'm assuming everyone is already aware of this, but Ontario Health did put out a memo, I think it's about 2 or 3 weeks ago, indicating that if you needed more time to prepare your C-QIP, that you could email them and I believe the ministry with the rationale for why you need extra time and when you propose to deliver the C-QIP. The other thing I would raise is that the C-QIP, my understanding from discussions with Ontario Health, is that the template for the collaborative quality improvement plan is open all year round. And so it's possible to adjust it as you go over time and add more content if there are new projects that you come up with.
Amber, I'm curious if I might ask you a follow-up question, because I know your OHT is fairly progressive. Are you, so you've got an extension. How are you dealing with the competing priorities, making it your own so that, or are you doing work in all 3 of those areas?
Yeah, so we don't have the extension yet, just to be clear. So we've asked at this point, I think we have a meeting maybe this week to discuss that. So I'm not sure where that's going to land. But we've been kind of thinking about the C-QIP indicators as being in alignment with COVID recovery, to which, that is a priority for OHTs to be involved in response and recovery. So that's how I think we've aligned it in our thinking around how it actually fits in. So, if you see a visual of our projects, we've got projects that are certainly aimed at population health management in our initial population of priority. And then we do have projects in the COVID response recovery space. So we've put the C-QIP kind of in that side of the visual. So that's how we've aligned our thinking. But, we just wanted more time because I think we would have been pressed for time regardless of Omicron. But, we were trying to pull partners together from across the system to really talk about this C-QIP, like a cross-sectoral quality and analytics working group, and we were going to do that first thing January. Well, then Omicron hit, right? So
okay, so it sounds as though you've got a fair amount of bandwidth. Some OHTs don't necessarily have the ability to focus on, a couple of priority populations and recovery plans, and so yeah, I can understand that you could manage that, but your message, or I should say, and your message about making sense of it is exactly what I was talking about, is how do you make sense of it? Meaning, how do you align it to what you're doing? And if it doesn't align, how do you modify it? Like, still report those, but how do you modify it to make it align and make sense? Because otherwise, others looking at it to say, what? Okay.
If it's helpful, Paula, not to say too much, but we had one partner at that first. We did pull the quality and analytics group together for the first time in the last 2 weeks. And we had one partner say, but these indicators don't have anything to do with our initial population of priority. So we did have that reaction. And then we had to, explain just what I did. So.
Okay, good. Thank you. Okay, so let's move on to the core of what I had hoped I could share with you as some initial thoughts and considerations for today. But as you can tell from the dialogue, many of you who are living it on the ground are even wiser than me. And learning from one another is a great strategy. So how how do we prioritize and align given the multiple tables that you're finding yourself sitting at? So one of these, and incidentally, we are going to share the slides after today, just so you know, if they're helpful to you. One of the questions is, in thinking about this, do most of your clients fall within the attributed population of one OHT versus the others you're sitting at? And if that's the case, can you allocate more of your energy to this OHT and play a more passive role in some of the others that you're sitting at? Another question is, are all OHTs involved in currently focused on mental health and addictions as a priority population? So it sounded as though a good number of you were party to OHTs or partners in OHTs where this was the case. So that's good. But if you're not, if you're an OHT member, because this is for the long term, and they will evolve through different subpopulations over time. So it doesn't mean you shouldn't be there, but maybe your focus just isn't on this particular OHT at this particular time. Can you allocate more of your energy to OHTs where perhaps it isn't the current focus, and then come back in a more major way with more players when that does become the focus? And the third thing to think about is, of those that are focused on mental health and addictions, which of the strategies that the OHT is taking align with your own organizational strategic plan? Because to the extent that those two things align, the OHT can help you to actually advance your own organizational strategic plan, so it doesn't always feel like double work. And the other is, to what extent can you leverage ongoing quality improvement work? So that kind of aligns with your strategic plan, that area I was just talking about. Are you currently doing work? It can work both ways. Is the OHT doing something that's on your strategic plan that you haven't yet addressed, and you can see that that's going to help you? And in the other direction, are you currently doing some quality improvement work that you could just say, oh, we're already working on this, let's just use some of this and spread it even further to align with the work that the OHT is doing, so that we're not starting new work for the OHT. There might be something even longer term that you might keep your eye on. For example, there might be something related to digital technology that you can see might really be a benefit. By staying at the table and staying involved, you might be able to foresee that as some of that evolves over time, and resources go into that sort of thing, your organization might actually be able to take advantage of something like that it might have been a lot slower for you to get to on your own. So just some thoughts about how you potentially limit some of your energy initially, or for now, and then where mental health and addictions is a focus, how you might think about alignment, leveraging, and longer term benefit for your organizations.
Paula, Rachel's got a question.
Sure. Do you want to put that?
So in terms of allocating more of our energy, so I've been doing that with one of our OHTs that's more youth, child and youth focused, super well organized. I'm feeling like, okay, I'm new ED. I've been in position 6 months, so I've got a good grasp of what's going on in one OHT. The other OHT, I've participated in a few meetings. I'm still trying to figure out, but now like this talk of E-QIPs and all that, I'm thinking, uh-oh. So what happens when you mention like, you allocate more of your energy to others and not some, is there an obligation? Like what happens if you are focusing a little bit more on one OHT rather than the other? Like what are your, can you help me understand like what my obligations would be to all of the OHTs that were members? Is there like a base?
Yeah, I mean, it varies. So partly it might be that so my vision of are you at the Leadership Council table for all of them?
I'm not sure for the OHT. I thought one of my staff was participating and I realized that they weren't. And so I have to go check that out. I am on one of them. Yeah. On the steering committee.
So, I mean, if you're not at the Leadership Council table for all of them, that is varied energy. because many of those leadership councils or collaboration councils are meeting monthly and doing a lot of the decision making. So that's all you've already, maybe without realizing it, have varied. The other is the extent to which you engage other people from your organization into working groups and committees. There's no assigned amount or degree of involvement. The question is, to what extent are you aligned? To what extent is this going to be beneficial for the residents you serve? Yes, you have a legislated accountability, but it depends on what they're focused on and whether you think engaging a lot of your staff and yourself. Now, I do have a belief that at the Leadership Council table, there ought to be a range of sectors represented long-term to make decisions about that continuum of care for better integration across the continuum of care, of course, with revolving tenure, but there ought to be representatives of sectors from across the continuum. So, you know, you may be that person for mental health and addictions at this point in time. They're not all necessarily set up exactly that way right now. In many cases, they started with signatories to an application, and whoever were the signatories, that's who's sitting at the Leadership Council table. But the question is, how is that going to evolve over time? And my personal lens is that if the objective is integrated care, then there ought to be representatives from across the sectors that need to be integrated. And you could be a decision maker at that table, but that doesn't necessarily mean that you're focused on priority populations for your, that's going to impact your organization for the next 2 years. But that doesn't mean you can't have a role in decision making for the attributable population overall. But you might, if their mental health and addictions is a focus, then you might also start engaging others from your organization in working groups, et cetera. And you might take on a little more as well at that leadership table. So those are the kinds of things I'm talking about. And it's also possible for you not to be the mental health and addictions assuming it was set up that way, for you not to be the member at the Leadership Council table, which is that ongoing, fairly frequent decision-making table, but rather be at a sector constituency table where you've got the ability, hopefully, if there's good communication set up, you've got the ability to influence on decisions, and you're hearing back about what's going on. Does that help? Okay.
Paula, there's a couple more comments. So Lorena Crosby has raised that many OHTs have levels of participation. Lynn Wardell commented that digital technology creates another challenge if you're involved in multiple OHTs, but they aren't all moving forward with the same digital technology. And Amber's responded to Lynn, totally agree. We've been advocating for standardized digital health tools, platforms wherever possible, in service to providers and patients, clients, caregivers.
I'm not even going down that rabbit hole today.
Well, and Lynn and I am pretty sure that Lynn and Amber are in the same OHT, at least one of them. So Amber and Lynn probably have already had these discussions at their mini tables.
Okay, yeah, that's a conversation for OHTs and OH in the ministry, and digital is not an area that I have expertise in, but I am aware of what you're talking about. And I feel your pain. I wanted to introduce some ways of thinking about accountability in some of this work. Some of you who know me will know that I love driver diagrams as a way of seeing the world. But I do think it's a good way to think about some of these things. I just wanted to introduce, for those of you who may not be familiar with them, they often have these headers, which are, what is the aim? So for a particular priority population, for example, what are we trying to accomplish? And then what are the drivers, generally evidence-based drivers that help us to achieve this aim? And then this is where the working groups start getting their own sort of customized approaches to these drivers. So what are the change initiatives? And then the particular ideas on the ground, and then how are we going to measure that there's good uptake of these change initiatives, and how are we going to measure whether we're achieving this aim? And the reason that this arrow goes this way is that everything we put in place here is all ultimately working to achieving the outcomes, shared outcomes on these shared aims. So that's what these look like. And I'm leveraging or customizing or adapting, whatever word you want to use, some work that I'm doing on the ground with the Algoma OHT in these next slides. So this is their example. It's one of their priority populations, which relates to frail elderly. But what you can see is they've actually combined two areas under here. One is sort of functional physical capability, and the other is mental health and well-being. And their focus here is on identification and management of depression. So that's just an intro slide. And so one of my key points was thinking about when we get into these priority population working groups, and or if you're sitting at a leadership council table overseeing what is happening and you're hearing about the progress of these working groups, thinking about what's already in place. So if you're one of the community mental health and addictions agencies, what programs do you already have in place that might, for example, be impacting that E-QIP indicator on, and particularly the denominator, which is about the number of ED visits that show up, sorry, the number of mental health and addictions individuals who end up in the ED in the first place. Do you already have things in place that you can say, hey, we provide X, Y, and Z already in the community. These should already be impacting, or you know what? We have these in place and we actually don't have full occupancy. We should do something about increasing the occupancy. And I know that in many cases you've got wait times. It's not occupancy that's the issue, but how can you get your wait times down to try and get more and more people into service delivery in programs you already have in place? So that's one message. Another is thinking about some other measures. So if we focus in on mental health and addictions and we say, okay, if their focus was management, identification and management of depression, beyond this E-QIP indicator, are there some other indicators which we might be better able to measure ourselves? Because we know any indicator that's a E-QIP indicator or an OHT indicator is going to be influenced by multiple organizations. That's the whole point. You need integrated care in order to impact it. And so no one organization on their own can impact it. So are you able to identify some outcomes at your organizational level, which will help you decide whether or not the pieces you're contributing to are achieving the outcomes you desire? And so this one relates to management of depression, and this one relates to client experience related to social supports in the community. And then moving a little bit further, what are the actual, so we've talked about what's already in place, but then if there are new initiatives that you're adding, what are those? And actually there might be 5 or 6 that relate to the mental health and addictions component of this. And maybe your organization is contributing 2 of these through some quality improvement work. And then I would say to you, for these 2 within your organization, are you able to measure some process and outcome measures that you can then stand up and say 6 months or a year, more likely a year from now, are we achieving these outcomes with our client population? And the process measures are, did we get 100% uptake of these changes, whatever they are, for our clients? Because then you can stand up and say, regardless of whether this lag indicator that's an OHT E-QIP indicator is moving, because it's so contingent on so many moving parts, you can at least say, we took responsibility and accountability for these 2 pieces, plus the services we already have in place, those other 2 or 3, whatever they are, we know we've got full uptake. You know, we're at 80 to 90% uptake with our clients, and we're actually achieving decent outcomes on at least outcome measures 5 and 6. So it's a way of thinking about your organization's contribution and thinking about limiting so that you're not overburdened. What are you going to take on? What's already in place? And how will you know you've achieved what you've committed to? And so some questions to be thinking about if you take these 2 on, and I've just put this in as an example, a peer support visitation program. What resources are going to be required? How are you going to phase the work so that you don't stress people out and overburden them within your own organization? Can you partner? So maybe there's a partner organization that's not currently at the table doing this. They're already a member, or maybe they're not even a member of the OHT. Can you partner to get the work done? Can you distribute leadership within the organization? Sometimes what we're seeing right now is that leaders are sitting at the leadership council table, and they're the ones who are also sitting at the working groups and other committees. And distributed leadership will help you for those areas that you've taken accountability for. And then this piece of how will you know? How will you know you've fulfilled your commitment and been successful, which I was just talking about. And this is just another example that I often will share as part of the leadership series. It's just another example of saying, if your organization is involved in these 2 areas, can your staff be measuring % uptake of what you've committed to? And can you find a couple of outcome measures that you can measure within your own agency to say you've achieved what you'd hope to achieve? Because this lag indicator is going to take a long time and is going to be contingent on way more than your single organization. So I'm just going to pause there for any questions just based on this concept of sort of seeing things this way. And I guess the 3 or a few key messages are some of the things you're already doing. Can you highlight those as contributing? Do you already have things in place, but maybe you do need some quality improvement to increase your ability to contribute to the OHT goals using those programs? Or are there some new things that need to be put in place? And can you figure out how to get other people involved, phase your work, and then really know whether or not you've achieved? At least if you're going to put the effort in and invest the resource, be able to stand up and say, we fulfilled our commitment. Question?
Nothing in the chat yet. Can I just add one comment though, just to what you were saying? I think one of the messages that we have been through E-QIP sharing is, as you said earlier, Paula, is make the QIP your own. So what are your priorities? What are you working on? And then the one thing that I think the work that Paula is sharing now can help you articulate when you're at your C-QIP table or when you're on your OHT tables is how is the work you are doing going to have an impact on some of those other measures? And so making those links between your activities and what the C-QIP indicators might be. And also that's potentially an opportunity to start thinking about collaborative work or integrated work with other organizations.
Yes, absolutely. But I do want to stress that you won't be able to draw, well, often there are other things even impacting your own organizational outcome measures. You will be able to point to what your contribution could be, might be to that denominator, for example, of the C-QIP indicator, but you won't be able to draw a cause and effect.
No, and you won't even be able to calculate your own data. You won't be able to calculate the impact of the work you're doing on any specific indicator.
Yeah. And then this is a lovely graph which demonstrates total success in decreasing wait times. This is significant change over time. So assuming you were working on that and you've demonstrated some sustained success at a new level of performance. The question is, how can you spread this work from one OHT to the others that you're involved in? And I would say even before you get to this lovely graph, because it takes time to I was going to say to create a graph. It actually takes 2 minutes to create a graph like this, but to actually impact an outcome like this takes a long time. So if you're sitting at multiple tables, can you advocate? Can you get some groups together through OH or through some other means that will enable you? And you're not the only ones who need this. Home care agencies also that are sitting at multiple tables. If there isn't some standardization of approaches to some of the new ways of delivering, it's going to be a real challenge for your organizations to be having to do things differently depending on the jurisdiction that you're involved with. So really, I would say as associations, as organizations, trying to do something, both advocacy now and as you move through this, to standardize. So that's the end of the core content for today. I thought we might end with some conversation, so I'd like to engage in this annotation, and I'll share with you how to do this. And we can maybe use this to leverage or start into some conversation, but I'm also happy to entertain questions or comments that others have in terms of your own experience that you think would be helpful for your colleagues. So what I'd like you to do is reflecting on the suggested strategies. So we've talked about making this E-QIP your own. So making sense of it, first of all, and adding in the things that you're working on if they don't align directly with the 3 mandatory indicators. Advocating for some degree of standardization now or in the future. Reallocating some of your energy based on where a majority of your population is, and or where they're focused on your client populations. And then thinking about alignment, leveraging your improvement work to serve the needs of the OHT, current service delivery, maybe improving it, but knowing that you're already partway there. And then longer term, thinking about how the OHT can help you advance your own organizational strategy. So where do you think, A, you're already working, or B, that you think this is a really good idea and you think you're going to move forward on thinking about how best to follow through on some of these strategies? If you use the stamp, the way you do that is at the top of your screen, you should see view options. And if you click on that, you should see annotate. If you click on annotate, you should see stamp, which kind of has a check mark, and you can use any of those symbols, a heart, a check mark, a star, and you can put as many as you want into, like, as many of the 4 squares as you want.
Paula, while people are filling that in, Elizabeth McKeeman has noted, I belong to an innovative OHT, and despite not being formally recognized, we provide leadership and meet with all local OHTs monthly. We have a newsletter. We try to share out the work or talk about not duplicating. Those are some of the small successes to date.
And which OHT is that, Elizabeth?
It's the Central Region Innovative OHT for Specialized Populations.
Oh, okay. Thank you.
Up in Simcoe County.
Yeah, yes. Okay, that's the one that Carol Lambie is involved with?
Yes.
Okay,
Yes.
yeah. Did some work with them early on patient or client and family engagement.
We're very much still doing that work.
Yes, and yes, I'm still doing some work with some of the folks who are involved with that, who I think we're going to be on the call today, but I'm not sure that they're on. So it looks like a little bit around the E-QIP. It looks like most of it is around that alignment. And so I'm happy for any of you who put check marks or whatever symbols into these to talk about whether you're already doing some of this and how that's playing out for you, or whether you're not, but you think it's a really good idea and how you think it will help you. This is your moment. Yes, Carrie, you can start us out. We always need someone to start us out.
Well, this might be a little bit of a tangent. This may be outside of something you can really talk about, but when you talk about advocating for the standardization across OHTs, again, I spoke earlier about the communication piece, but part of it on the ground is really understanding the relationships right now with respect to the Ministry of Health, Ontario Health Teams, Ontario Health, the Centre of Excellence, and how you move in these spaces, because on the ground, the OHTs themselves are different, but the funding mechanisms, the LINs are not standardized. So even within an OHT, what service delivery is available that you can build on could only apply to kind of half of your population that you serve as a community-based organization. Right, so in Peel we've got the Mississauga Halton and we've got Brampton, right? So they're very different. So I don't know if you can speak about what we might be able to do to influence or to communicate as a sector upwards to try and influence change, not just what we can do, but some of the bigger system barriers that make it really difficult to do what's right for families, kids and families, youth. And so that's the LIN side. We also, for those that sit on the lead agency consortium in terms of child and youth mental health, our reporting mechanisms is through 5 regions and 5 program supervisors. And we spend an awful lot of time trying to message up the need for consistent messaging to help us do our work. So maybe it's just a comment, maybe it's not something you can talk about, but strategies to kind of bring together not just the voice of one area, but the voices of all of us to see if there can be some improvements in the overarching structures that are not enablers. They're really barriers to doing all these things that you're talking about.
Yeah, I mean, I can't speak to the organizational barriers of the agencies, and we will continue to operate in a dynamic environment where there are competing priorities. There's just no question about that. It's never ended. It's just continuing. What I do think there may be an opportunity for, I mean, OH, and now you've got within mental health, the agency, the Center for Excellence within mental health. And if there are some common challenges that are being addressed across multiple OHTs, again, I think in driver diagrams, but that is the kind of thing, those standard approaches that had started to be developed. And it doesn't mean that they can't be customized locally, but if there can be some standardized approach, if the Center for Excellence could work with multiple OHTs on some common aims, and try to get some standard approaches. And then, leaders such as yourself, when it gets to customizing, can be advocates for, we've all aligned with this standardized general approach, but the way intake or the way something specific on the ground is being suggested is actually quite different. Given that we've all agreed at this high level to standardize, can we get some agreement? Because otherwise we can't operate following 4 different procedures, depending on where someone, is landing in hospital or where their primary care physician is. So it's that kind of standardization that I'm suggesting doesn't seem yet to be forthcoming. I can tell you that on central support calls, I'm hearing agencies, meaning OH and others, agree that that's necessary, but thus far, I really haven't heard it happening in a major way. And so, sometimes leadership has to happen from the ground up. Partly also, I mean, some of the system barriers, in my experience, and it's early days for this, but in my experience in the past in doing quality improvement work at a system level, one of the benefits of having system partners at the table was that when there were barriers that were beyond the scope of leaders from organizations to manage, then you could go to those system partners and say, we're doing X, Y, Z. We're doing all of this work that's within our control, but this is working against us, or, this barrier is preventing us from doing something. And I'm not suggesting that it will be a panacea and that everything will be addressed, but at least they can start to say, yeah, we're in this with you. And yes, that is our role. And yes, we ought to do something to see if we can do something about that. So those are the kinds of things that I think can happen, but it does take leadership. And I think it takes leadership collectively from multiple organizations or OHTs going to groups like the Center for Excellence to say, we're all working on this. Can we think about a standardized approach? And then working on barriers. It takes leadership voice to raise those in the first place. Does that help?
Yes, thank you.
Anyone else want to speak to what's on this annotation, or the next slide is just Q&A. So I'm happy to entertain other questions or reflections that people have.
Nothing else in the chat, Paula.
Okay.
And I'm noticing we have lost some people, I think, just with conflicts and competing priorities. So
I'll raise a question that was raised to me when we were planning this, just maybe while somebody else is thinking about a question or a reflection, is there was a question asked to me of, if I'm a member of an OHT and I don't feel like I have voice at the table, are you suggesting that we just leave that OHT and spend our time where we do have voice? And my answer to that was no, not necessarily, because I think it's really important to think about your client population and where a majority of your client population is served, because walking away from the table rather than trying to improve authentic collaboration at a table is not going to serve your clients well over the long term, because you need to be involved and be there, because that's where a majority of your clients are going to end up being serviced, assuming this goes long term, which is the plan. So then there are other strategies that we talk about at the leadership series for Advance, which is about how do you engage in and how do you promote and encourage authentic collaboration at a table where all members are respected and heard and part of collective collaborative decision making. Any other? Yes, Lorena. Go ahead.
I don't know if this is a question or reflection, but in speaking with competing priorities and trying to align the various priorities, there are still things that keep rolling out that end up being not a choice. So I'll give you an example with Ontario Health East rolling out Access to MHA. We're in the midst of, so I'm one of 3 OHTs. Fortunately, things are reasonably well aligning in terms of the mental health and addictions work within the 3 OHTs. However, partway into the work, then Ontario Health East came out with developing Access MHA, which we all paused to think, well, wasn't part of our mandate to be making sure that services are available through your OHT, and potentially you would have one contact number to call, and then such programs come out as Access MHA that is by the ministry, by OH East, and it's left us scratching our head in the sense of it's also a very broad geography so I'm in Lanark, Leeds, Grenville, but the the geography of OHTs is quite broad. So we potentially will have clients, for example, going through this massive access mechanism that who knows how it's going to align with the work of our own OHT. So just, I guess I'm just putting that out in the sense of where we're already trying to align work within the children's mental health sector, locally, provincially. Now we have, well, for us, 3 OHTs, and then things keep coming out on top of it. So you just think you might get a sense of where things are going, something else comes out and something else comes out. Any sense of sort of, can you comment on that? Or
well, I think it's going to continue to happen. And my only comment is, if I were you, I would be going to have conversations. I would get the leadership from the OHTs and I would go and have a conversation with OH to say, because OH is totally behind OHTs. Help us understand how to make sense of this. That's what I would be doing.
We kind of have, and the response is just they're going ahead with it. So I think there's times where we can push back, but the decision's already made. So it's now, how are you going to realign so that you make this fit with what's happening? And I'm not saying there might not be positive outcomes for families, but I think it's, where we're sitting right now, it may create another whole level of confusion. But it just seems a bit counterintuitive to what the intent was of the OHTs. So it makes it more difficult to align what we're doing locally when things come out that make you think that's got, it's such a broad area. It's even outside of, our OHT service area. But thank you.
The only other thing I might suggest, and I don't know whether this is relevant or not, there are a couple of OHTs that are starting to form regionally. So I know that, for example, the Hastings Prince Edward County OHT is sort of it's approved, but it's early days, and they have a regional sort of structure and then constellations for kind of sub groups under it. And so whether I'm only saying there might be an analogy that, as they think about how they're doing things regionally, but then how will that play out locally? Maybe there's a way of thinking about this sort of broad strategy and how 3 OHTs figure that out or align underneath that. So maybe talking to them and just, I don't know whether that's an appropriate analogy or not, but
thank you.
I'm thinking on my feet, which is scary.
Elizabeth, I saw that you'd had your hand up. Elizabeth McKeeman, I don't know if I saw you put your hand down, but just wondering if you still had a question.
Well, I took it down just, overthinking it, I guess. But my board, we made a decision to only join 2 of the potential 6 OHTs in our area. And one of the reasons was well, part of it was workload in terms of being able to sit on that many OHTs. The other was financial. I don't know if you have any insight or thoughts or a crystal ball into the future, but one of their concerns that I supported and shared was, would we end up being vulnerable in terms of, being at a table, expecting to be able to provide funding for things, and how would you possibly do that on 6 different tables? And so part of it, I guess, was fear of the unknown, and we didn't do that. It feels more manageable to only be on 2, but I was wondering if you have any insight around, is that a real concern for agencies when you're stretched all over the place, that potentially your funding could get stretched all over the place and you lose more and more control, I guess, over what was your mandate, especially because child and youth mental health is new to health and they don't really seem to understand us yet.
I mean, I think you're really talking about 2 variables there. One is funding and one is governance. In the early days, where it really is collaboration, and for the most part, there aren't any legal entities being formed by the organizations that are partners in OHTs. it comes down to early funding, and funding for operations has, beyond a secretariat, has not been impacted at this point in time. And how that will play out, your guess is as good as mine. I mean, I think the long-term vision in Ontario is outcomes-based funding, but we're a long way from realizing that for every client. In the early days, there's been a mix in the way in which people have supported that secretariat, those roles. It's been a mix of solely the implementation funding, that's ministry funding, to implementation funding plus some contributions from some or all partners. Generally, when it's all partners, it's based on percentage of budget. And I can imagine that there might be some strategies or some formulae for organizations that are sitting at multiple OHTs. And the other is in kind. So, I mean, it depends how you count resources too, whether it's just, dollars budget, or whether it's time of people as well. And both can be considerable. So yes, I mean, depending on, your major versus minor involvement in terms of time commitment of people, which is resource, you could become quite stretched. I can't speak to the longer term funding because I don't have any more of a crystal ball than you do. I do think, and we are having conversations with people about governance, there are at least 2 OHTs that we know of that have done something along the lines of changing some legal entities. Whether that's an umbrella organization, like some legal incorporation. The long term could look like a merged organization, in which case you're not looking to retain control for an individual organization. It's kind of like a regional health authority out west, where probably some organizations would be subcontracted because they do fall across multiple OHT boundaries where you can't merge into a single one. But those are, whether that ever gets realized long term, and what kind of funding goes along with that, that's a big crystal ball.
Paula, Daniel Shiravar raised that about the financial, that in terms of contributions and getting stretched. He raised that, especially when it comes to taxation or contributions, less recontrol. And I just wanted to ask, Daniel, when you talk about taxation or contributions, can you elaborate a little bit?
So as OHTs look at sustainability, there's some conversations around what can they contribute to kind of support, say, the backbone. But for those agency partners we have who are part of a number of OHTs, they're feeling that exponentially, right?
Yeah, that's I had a feeling that's what you were talking about. And when you say less regarding control, I guess that means that you don't have control over whether you can or cannot submit to contribute. Yeah.
With the 3 or 4 OHTs I've been involved with, they're less worried about control. They're more worried about how do we sustain this, how do we manage the contribution. I haven't seen conflict over control. It's more about sustaining the pace, how we involved, how we plugged in, and the alignment that was had earlier.
Thank you for clarifying.
I know we've just got a few minutes left. If there are any other questions or reflections, happy to hear them. If anyone else has any insights that could be helpful to your colleagues, happy to hear those as well.
There's just some thank yous in the chat at this point.
Okay, well, if there are no other questions, I want to thank you for your engagement, for your very helpful comments. And I hope that maybe this has raised a few questions or considerations that perhaps you might not have thought about before, maybe helps you to make some sense of what's going on around you. As I said, I had no silver bullets. And even all of us collectively can't solve all of our problems, but
I think it's a matter of time. And I wanted to take a minute to just thank Paula for the time and effort she's put into putting this together for us and for taking us through this discussion. It's been very helpful for me to hear the approach, and especially as we think about through E-QIP how we can support community agencies in the work you're doing. So thank you, Paula. And for those of you who were asking about the recording, yes, we will have the slides and the recording available after today. And of course, we also have a presentation available. Paula will be delivering it again on March 1st. If there are others within your organization or if others within your OHT who you think would benefit from attending. And I want to thank the participants for joining us, and I hope that you've enjoyed today. As I said, we will make everything, all the content available after today, probably in the next day or so. All right, thanks everyone. Have a good rest of your day.